All right, let's talk about something that can feel, well, like a total mystery. You've got this whole menu of antidepressants, right? So how on earth does a doctor pick the right one for you? It's not just a guess. Believe it or not, there's a real science to it, a framework they follow, and that's what we're going to break down today.
So, this is the big question, isn't it? If you've ever found yourself wondering about this, trust me, you are definitely not alone. It seems super complex from the outside, but I promise, by the time we're done here, you're going to have a really clear picture of the key things that guide that decision. Okay, so where do we start? Let's take a look at some of the new kids on the block. Seeing what these newer drugs bring to the table is a great way to understand how the whole field is evolving and, what kind of new pros and cons doctors are weighing these days.
First up, we've got vortioxetine, which you might know as Trintellix. Now, its official label is a serotonin modulator, which is just a fancy way of saying it works a little differently than your standard SSRI. It definitely works, no question there. But, and this is a big but right out of the gate, we have to talk about cost. If your insurance doesn't cover it, this one can be pretty pricey.
And this is where we get to the real trade-offs, right? On the plus side, and this is a huge deal for a lot of people, it might have fewer sexual side effects. That's a massive problem with many other antidepressants. There's also this small measurable boost in cognition, though honestly, the jury's still out on how much that helps in day-to-day life. But then you flip to the con side. Nausea is a really common one, we already mentioned the cost, and then there's this technical bit. It messes with a certain pathway in your liver. All that means is your doctor has to be extra careful about any other meds you're on.
All right, next on our list is levolmilnacipran, or Fetsima. So this one is an SNRI, which is a class you've probably heard of, but it's got a special twist. Think of it like a regular SNRI that went to the gym and only worked on its norepinephrine muscles. That's the neurotransmitter tied to things like energy and focus. And Fetsima hits that norepinephrine way harder than its cousins like venlafaxine.
And that right there tells you exactly what its niche is. That huge norepinephrine kick, it can be a real game changer for people whose depression comes with that soul-crushing fatigue. It's like a specialized tool for a specific job. The catch, of course, is that the very same thing that helps also increases the risk of some pretty specific side effects, like urinary hesitancy and even erectile dysfunction.
Okay, so we've seen a couple of the newer options. Now let's switch gears and look at some of the older drugs. I'm talking about the ones that used to be super popular but are now used a bit more cautiously. Figuring out why they're less of a go-to choice is actually a huge piece of the puzzle for understanding the whole selection process.
Let's start with paroxetine, better known as Paxil. I love this description. High power, high maintenance, because that's exactly what it is. It can be a powerhouse, an absolute lifesaver for conditions like panic disorder or PTSD. But, and you knew there was a but, the maintenance part is rough. It is notoriously difficult to stop taking. The withdrawal or discontinuation symptoms can be really significant. Plus, it has these other effects that make it a really bad idea for older adults.
And then, of course, there's fluoxetine, Prozac. Now, Prozac has a very important exception to the less preferred rule. For kids and teens, it is still the absolute gold standard. But for most adults, its biggest feature is also its biggest bug. It has a super long half-life. That just means it hangs around in your system for a really long time after you take it. So if you need to change your dose or switch to something else, it becomes this really slow, drawn-out process.
So we've looked at the new, we've looked at the old. How does a doctor actually put all these pieces together to make a choice? This is what we've been building towards. We're getting to the core of it now. The actual framework, the decision tree that clinicians use to find the right fit for each person. And you know what? It all boils down to a pretty straightforward three-part balancing act. Number 1, efficacy. Simple enough. Does this stuff actually work? Number 2, tolerability. This is huge. Can you live with the side effects? And number 3, acceptability. Does it play nice with your other health issues, your other meds? Basically, does it fit into your life?
Let's talk about that first one, efficacy. And I've got some really good news for you, straight from the official Canadian guidelines. When it comes to the modern antidepressants, you almost can't go wrong. Most of them are considered totally effective as a first shot. So the game isn't just about finding something that works. It's about being what the experts call incrementally smarter. And you do that by looking hard at those other two factors.
And this right here, this is where it all clicks into place. This table basically shows you the expert report card for different drugs on those acceptability factors. Just look. See down at the bottom? Paracetin and fluoxetine, they get unfavorable grades for things like drug interactions and sexual side effects. Now look up at the top. You've got escitalopram, sertraline. They're getting favorable marks across the board. See the pattern? This is exactly why they tend to be the first ones doctors reach for. So you take that three-part framework, you balance efficacy, tolerability, and acceptability, and where does it lead you? Well, it leads us right here. Let's pull back the curtain on the 2 meds that more often than not end up being the top go-to choices for a first prescription.
First on that list is escitalopram, or Cipralex. The best way to think about this one is as the great all-rounder. If the absolute #1 priority is, let's not have a bunch of side effects, this is almost always the first choice. Its whole reputation is built on being really, really well tolerated by most people.
And then there's the other big contender, sertraline, which you definitely know is Zoloft. So if escitalopram is our all-rounder, then sertraline is the specialist. It's a fantastic, powerful drug, but it really shines because we have an absolute mountain of safety data for it in very specific situations and for some really vulnerable groups of people.
And that's the key, right? Knowing when to call in the specialist. So, sertraline becomes the clear frontrunner for patients who are pregnant or breastfeeding, or for someone who's had cardiovascular problems, maybe a past stroke or heart attack. In those very specific cases, its rock-solid safety record makes it the obvious, incrementally smarter pick.
Which brings us full circle, right back to this amazing quote from the guidelines. It just nails the whole point of what we've been talking about. Picking that first antidepressant, it's not some desperate search for a magic bullet. Why? Because most of them are probably going to work. The real art and science is in the process, the thoughtful process of finding the one that works best and fits best for the actual unique person right there in the room.
So there you have it. That's the framework doctors are using right now, today. But it kind of makes you wonder, what's next? As we get better and better at understanding our own individual genetics and biology, what could a truly personalized treatment for depression even look like? That's the really exciting frontier. Thanks so much for joining me.